this morning with regards to the second of the series of webinars out of the 6 in total for pediatric dermatology in ER. The first lecture is available on our YouTube channel as well as on our Facebook. So please do refer to that if needed at any point and share it with your colleagues. Now, just a little bit of introduction for those who have joined us for the first time today. I'm Dr. Amjad Khan, pediatric dermatologist at Shifa International Hospitals Islamabad, and I'm the first in Pakistan, a UK-trained pediatric dermatologist. And after working in UK, predominantly in London and Bristol for nearly 2 decades. I returned nearly 2 months ago and have started running a purpose-run pediatric dermatology service at Shifa International Hospital in Islamabad. Now, with regards to the topics for today, well, the disclaimer, this is a pure academic CME event, and we have myself, our CME team, and my organization, my hospital, has no financial interest to declare with regards to this activity. Now, pediatric dermatology in ER. So this is the topic 2 or lecture 2 with the inflammatory dermatosis in focus. And the main idea behind today's discussion is that we will go into appropriate depth of different topics to make sure that when our frontline staff, ER colleagues, pediatricians, residents, dermatologists, when they see a young child with inflammatory dermatosis, then they know how to troubleshoot them. Obviously, dermatology is a huge specialty. Every topic, every disease is very we can go into depth, and even one lecture for even a part of the disease is small, but we will try to cater multiple diseases in this one lecture. It will go along lines of this sort of presentation. So like you can see the topics covered here. With Pityriasis and Lichenoid diseases or dermatosis, we have quite a few within them, and then we'll talk about them as well. Psoriasis is undoubtedly the biggest topic for today. It is widely sort of prevalent in the society, and there are so many treatment options. And previously people used to say, at least here in this part of the world, kuch nahi ho sakta, bas ye treatment lijiye aur ho gaya to ho gaya, warna Allah khair karega. So aap pareshan mat ho, there are so many options, and nowadays psoriasis has extensive research on its backing on the background, and there are so many new products. So we'll talk about them anyway. So let's come through to the first topic or first disease of the day, psoriasis. If you see an ER or in your clinic as a frontline doctor, psoriasis is predominantly inherited. It's a chronic inflammatory condition. Roughly 2% of the population has it. So obviously, as of, let's say we take Islamabad, where we are based, we have approximate a population of 7 to 8 million. So in that you can see we have at least 1 to 1.5 million people with psoriasis. That's the statistics. Now, diagnosis, 2% of the disease is diagnosed under 2 years of age and 10% under the age of 10. And psoriatic arthropathy, you'll talk about it a bit later as well, but it precedes psoriasis in most cases in young children. So whenever you see a young child with psoriasis, always ask about joint pains. And if there is any swelling, if there is any involvement. Now, do remember jaw and neck is part of the rheumatological examination of the joints. So you have to ask about those as well. Issues with chewing, so obviously the jaw, joint, TMJ, or the neck pain. Now, there are different variants of psoriasis. I've listed them here, but it's easier to see the photograph rather than seeing them. remembering them from the text. This is a general photograph. You can see some of them are pediatrics, some of them are adults. I just wanted to show you a whole array of the disease. And the right lower corner has got issues with psoriatic arthropathy. So just to remember, mostly it is erosive arthropathy. So if we treat it early, there is less damage to the joint involved. And it's not only skin. For dermatologists who already know these, or the dermatology trainee, there is a difference. But for my other colleagues from other specialties, please do remember, dermatology is not only skin deep, it has other parts involved: hairs, nails, teeth, and even the joints in some diseases. And there are systemic involvements as well. We'll talk about them shortly. Clinical spectrum. So you can see for psoriasis, as soon as it comes through to your mind or your differential, the parts of the body we have to look at. So extensor surfaces, so elbows, knees, hairs, so scalp psoriasis, very common, behind the ears, inside the ears. So severe psoriasis, we usually advise ENT reviews on yearly basis, because the external auditory canal can be affected, and it can affect on hearing as well. Now, these are the nail and scalp involvement photographs, and you can see on the right photograph psoriatic arthritis, where the distal joints, especially in the thumbs, are bilaterally involved, and the right index finger as the little finger as well. Now, this is the spectrum. So plaque psoriasis, pustular psoriasis, which is less common. I've got another photograph to share from one of my colleagues' presentations from EADV in 2018. Flexural psoriasis, umbilical area, always need to be looked at. In kids, natal cleft, upper end of the buttock area, buttock region, that needs to be reviewed as well. They wouldn't volunteer to show you until unless you ask. Gutted psoriasis, again, more common in young people. And then erythrodermic. Erythrodermic psoriasis is an emergency, dermatological emergency. Erythroderma is a dermatological emergency. We'll talk about it in one of our last lectures, where we will be discussing dermatological emergencies. Pustular psoriasis, you can see photo is courtesy of my colleague from States, Dr. Qureshi. And there are a few other photographs from his presentation as well as from Dermnet, Amjad, and Google stock images. Now, psoriasis, chronic inflammatory skin condition, we have to think about it. It's not infectious, it's non-transmissible. So please do encourage your patients and their families actually that this is not contagious. Mostly genetic factors. We roughly say between 70 to 80% is genetic influence. And trigger factors. So trigger factors is behavior, stress, infection. All these are trigger factors. In our society, psoriasis allergy nahi hai. ये ध्यान में रखिएगा, psoriasis allergy नहीं है. It's not an allergy. It's an immune system activation and increased skin proliferation and renewal. Now, arthropathy is usually up to 30% in general cases. Associated with cardiovascular disease, metabolic syndrome, malignancies. So we have to think outside the box here. Inflammatory bowel disease and multiple sclerosis, so many other things. And not to forget about mental health. In patients with chronic skin conditions, mental health is predominantly ignored because of so many things going on, but please do remember that as part of your medical assessment. Now, severity of psoriasis, you can see mild, moderate, and severe. Generally, we say body surface area less than 10%, more than 10%, psoriasis activity score less than 10, more than 10, or dermatology quality of life score less than 10 and more than 10. Comorbidities, you can see diabetes, cardiovascular problems, metabolic syndrome, obesity, and arthritis. So many things to look out for. Usually, it's advisable to sort of screen them yearly, predominantly in adults rather than in pediatrics, if you are seeing them on a long-term basis, or at least watch out for them. Now, erythrodermic psoriasis, this is an adult patient, but you can see this is a dermatological or medical emergency. Please don't send these patients home. I've recently seen a psoriatic patient a young child in Peshawar in my outreach clinic, 13, 14-year-old, and from last 2 years has been nearly erythrodermic. And until unless somebody put a foot down, here you as a clinician, you have to put your foot down and say, well, this child or this person needs admission rather than sending him home. I can understand the practices are slightly different here because of the logistics, social fabric, and the way medical services are run. बट जब तक आप पेशेंट को एजुकेट नहीं करेंगे, पेशेंट की फैमिली को एजुकेट नहीं करेंगे, उन्हें बताएंगे नहीं कि ये सिर्फ जल्द नहीं है, ये जल्द के नीचे सारे के सारी जिस्म जो है उसका इशू है. एंड एक्चुअली द वे आई डिस्क्राइब्ड इट टू द फैमिली हु आर रीजनेबली वेल इन्फॉर्म्ड कि इस वक्त बच्चे का इम्यून सिस्टम और जिस्म और खून जो है वो इस वक्त हालत जंग में है. जब तक इसकी खिदमत, इसकी हेल्प नहीं की जाएगी, इसका सपोर्ट नहीं किया जाएगा, अनफॉर्चुनेटली बच्चा ठीक नहीं होगा. Now, thinking outside the box, psoriasis is one of the sort of diseases where in dermatological sciences where we look at other organs, preferably the lifestyle as well. And there is a lot of research into it. So anxiety, depression, self-esteem, loss of self-confidence, and stigmatization in the society, because it is very much evident. Treatment. Let's come as a clinician. Yes, I can understand a lot of you would say, well, just jump up to the treatment. Why should we think about other things? I can totally understand, but until unless we know the etiology, pathophysiology, comorbidities, effect on the life of the patient, it's very difficult to treat just क्योंकि जिस भी डॉक्टर के पास मरीज आपका जाएगा वो क्रीम देके उसको घर भिजवा दे और बताए कुछ ना, तो अनफॉर्चुनेटली वक्त के साथ साथ पेशेंट इसीलिए डॉक्टर्स पर एतबार नहीं करते, क्योंकि वी हैव टू टेक टाइम, हमें टाइम लगा के पेशेंट को और उसकी फैमिली को एजुकेट करना है. नाउ दीज आर द ट्रीटमेंट ऑप्शंस. इफ यू लुक, topical agents, so creams, ointments, gels, we'll come to that. Next slides are, so don't worry, we'll go extensively in detail. This is a very big topic. Phototherapy, light therapy, it is available. UVB is available with us. To my understanding, in Peshawar, it is available as well in Lady Reading Hospital. One of my colleagues, Professor Mahmoud Noor, runs the service. While in other hospitals and locally in your city, please look out and watch out and liaise. One thing which is substantially lacking here, what I've realized after coming back to Pakistan, is networking, working with your other colleagues. हम एक दूसरे के जब तक दोस्त नहीं होंगे, नेटवर्क नहीं बनाएंगे, हमारे पेशेंट्स उससे बेनिफिट नहीं उठा सकेंगे. वी हैव टू नो आवर लिमिट्स, कब तक हम एक पेशेंट को ट्रीट कर सकते हैं, और व्हेन वी नीड टू रेफर देम अहेड टू समबडी एल्स विद द एक्सपर्टीज एंड स्पेशलिस्ट इंटरेस्ट इन दैट एरिया. Coming to the oral medications, there are systemic agents like methotrexate, cyclosporin, acetretin, time-tested, historic, well-versed. Most of us are well-versed with them. Then there are newer products, biologics. So there were some historic biologics, like historic means in the last 15, 20 years, 30 years, anti-TNF ones. Newer ones are coming thick and fast. This is one of the most rapidly expanding and changing horizon in dermatology across the globe. Biologic agents, not only for psoriasis, but for other conditions as well. We'll talk about them in detail. So again, topical agents, steroids, vitamin D analogs, retinoids, calcitonin inhibitors. These are all present in Pakistan to my knowledge. Coal tar products, yes. Anthralin, I'm not sure. I haven't seen anyone using them, but I'm sure it will be available if further looked into. Systemic agents, most of them are available here. We'll talk through them as well. Biologic agents, 1 or 2 are available in Pakistan, not all of them. And phototherapy, it's available depending on the locality where you are. Now, treatment options. Emollients, moisturizer. That's because of reduction in scaling, relieves itching. So use something with a mild urea. You can use lactic acid or salicylic acid based products, but be careful in young children. And then vitamin D analogs. So although the international name is Dovonex, we have Devinex, I think, which is available here, calcipotriol. Then topical steroids, Dovobat or Devibat here. And then we have foam and gel versions as well. I'm not sure if the foam is available here, but we might have to look into that, especially with the collaboration of our big citywide pharmacies. Salicylic acid preparations are available. Diprosalic is Betasalic and other products. There are so many other different names. I'm just giving you the names so at least you know they are available. And if you need to, then you can consider using them appropriately. Enstellar foam, it's a sort of a same combination as Dovabet, but the efficacy is far better. It was hugely expensive in UK, but I hope there is an alternative product available here in Pakistan for the betterment of our patients. Other treatment options, topical tar products. So the problem with them is the restriction is they have odor, and sometimes they stain the clothes and the skin. So international products are Exorex, you can see T-Gel, Alphocell, but there are other local products available here as well. Erythronol, it's very irritant, and more in flexural areas, it's much more irritant, but we usually advise short contact, an hour or so once a day. Erythro cream is another product available. It's licensed in children. Mecanol, and Sorin combo or tar erythronol combinations. So if we have compounding or pharmacy available who can do compounding for us, we can consider using them as well. Other treatment options. Second line, usually what we say, calcineurin inhibitor in young children. Protopic, they are immune modulator. It's called eczemas here, 0.03 and 0.1. UVB light therapy, we have also discussed topical agents and biologic agents. So here, the reason I've written vintage etanercept because there are so many new products. And stellar foam, I've shown you the photograph. This was head-to-head with the market leader at that point. Teclonex and ointment, it was as good as that. It's licensed after 12 years of age. And you can see even Teclonex is licensed after 12 years of age. And the reason I've shown this photograph or this slide here, because you can see the body surface area. We are all worried about steroid use in young children, but you can see if up to 30% of the body surface area, Teclonex was used for roughly a month and 60 gram a week. So still there was no issue on HPA access. So although we have to be cautious, but we have to give appropriate amount of medicine so that the body response is better and the skin gets improved with the treatment. Other options, so let's go through one after another. Acitretin, oral use, not used in pregnancy. Liver enzymes, hypertriglyceridemia, and do consider reducing it the dose after combining it with the light therapy as indicated. Cyclosporin, it's twice a day, much more used and practiced here in Pakistan. I've seen quick response, and be cautious about the effects on the kidney, blood pressure, even in young children, and hematological monitoring. Please do keep an eye on that. Methotrexate, much more safer option. I prefer that because we slowly build up the dose, and we have extensive experience. Some of us have, we have our own personal preferences. Out of the lot for pediatrics, I use methotrexate as a preference. TNF inhibitors, so you can see adalimumab, which is licensed, etanercept, which is licensed, and infliximab. So all these are licensed, but they are generalized. So I will show you a photograph here. You can see the cascade. So TNF inhibitors or blockers are very early in the cascade. So what happens? They block the whole cascade and hence have some unwanted effects as well. But now there are very much specific agents which do what we generally say here, a surgical strike. So they do very specific targeted approach on the pathway, and then helps with the psoriasis, but have less and less unwanted alternative side effects. IL-12, IL-23, ustekinumab, this is licensed for children. IL-17A, I will show you one. This is, as we speak, I think it's been considered. I hope it's been licensed by the time some of us want to use it. I don't think it's available in Pakistan yet. Please correct me if I'm wrong, but the first two are adalimumab, etanercept, infliximab, ustekinumab. They are available in different parts of the country according to the supply chain. Now then, coming to PDE4 inhibitors, fantastic medicines. Apremilast, it's not yet licensed for young children. but PDE2 inhibitors are licensed for children for severe eczema. So I'm hopeful that FDA will consider PDE4 for psoriasis in children. There might be a trial going out, not to my knowledge. So again, I will wait to hear from my other colleagues or get an update in one of the conferences. So that's another thing with limited side effects. It's a fantastic product as another alternative. And other names, I wouldn't go into detail, but JAK inhibitors, which is you can see the fourth on the list. It's Janus, which is Janus kinase inhibitor or JAK inhibitors. They have effects in very many different. They're magic products, not only in psoriasis but alopecia and so many other skin conditions and other medical issues. So do watch out the space. They might change the a whole practice for us in next decade or so. So this is in a nutshell, TNF inhibitors, IL-12, IL-23, IL-17A, and PDE4 inhibitors. Now, these are licensed products for children, adalimumab, as I mentioned, after 4 years of age, etanercept, and ustekinumab, and all three are available in Pakistan. This is the sort of cascade. You can see blocking it earlier or later. That has its own effects. Now, just to show you one before concluding the psoriasis, anti-IL-17, within 4 weeks, you can see the response. So previously, when we were using medicines, treatments, हम यहाँ पाकिस्तान में भी settle down for a little. कुछ थोड़ा भी improvement हो तो हम कहते हैं जी अल्लाह का शुक्र है, होना भी चाहिए. But internationally, for psoriasis, we are aiming for 90% and even 100% clearance nowadays. So don't lose the hope if you are a patient, if you have a relative, or if you're a doctor and looking after a bunch of patients with psoriasis. There are so many options. You can see the skin clearance. Unfortunately, yes, these biologic products are hugely expensive, but some people will be affording. And hopefully with this health sehat card, at some point, it will be part of the prescription regimen and it will cover that. This is IL-17A TALTS, and you have seen the photograph, fantastic outcome. And it is actually licensed because the research was done on 6 year and older. Now, summary, it's a multi-system disease. Inflammation is the main issue, dysregulation of the immune system. And then there are so many treatment options as we have discussed today. Now, coming to other topics, HSP or Henoch-Schönlein purpura, very common, especially pediatric colleagues see them, emergency department physicians see them. And you can see it's one of the most common forms of systemic vasculitis, more predominantly in the lower legs. It can happen in adults as well, so don't get confused. But again, more common in young children. Obviously, the first case was seen by William Haberden, or at least documented by the physician, but it was not until 1837 when Schönlein considered and described similar things, naming it as purpura rubra, and then the penny dropped and the name was given, hence HSP, Henoch-Schönlein purpura. More common in children, mostly with strep infection, male predominance, and more in summer and spring. After upper respiratory tract infection, vaccinations, insect bites, so any trigger which affects our immune system can result in this. Palpable purpura is nearly 100%, but hematuria. So think of kidneys. HSP, think of kidneys, please. Tummy and kidneys. So if you think of tummy, intestinal obstruction, and kidneys, these are the two sort of things outside the skin. And then arthralgia or joint issues. Joint issues are more common in adults as compared to kids, but it is still present. Mostly joint issues are self-limiting. Abdominal pain, obviously we'll talk about it as well. And now labs. What do we need to do? Well, yes, we know elevated IgA, but do we need to do IgA to diagnose HSP or a skin sort of biopsy? Sometimes we have to revert to that if there is diagnostic uncertainty, or even kidney biopsy, renal biopsy. Now, as part of once the diagnosis is made, we'll have to think about, basic blood test, infection markers, complement immunoglobulins, and renal ultrasound. Height, weight, and blood pressure, along with urine dip, is part of regular monitoring. And you can see skin biopsy will show IgA and C3 deposition and leukocytoclastic vasculitis. Now, treatment consideration, abdominal pain usually settles, so we don't need to give anything beyond simple analgesia, but if it continues, please discuss with pediatric gastroenterologist. Most of the cities will have one or two, if not more, and because systemic steroids are indicated. I have used it personally, but I wouldn't like to mention the dose just because you need to discuss your patient with your pediatric gastroenterologist, just because there are so many other things, options, and the dose is adjusted according to the signs and symptoms. If the pain, abdominal pain persists and there is blood in the stool, so always with the pain after HSP, there is tummy pain, ask or wait for the stools, see if there is blood in there because of intussusception. Consider ultrasound and surgical option if need to be. Now, generally supportive measures, it's the surgical opinion rather than going interventioning, because obviously the gastroenterologist will lead the way with the systemic steroids, just to clear that up. Now, with NSAIDs should be given or considered at least, but not if renal disease is present. So do consider renal disease always when you're treating HSP. For skin manifestations for which we are here, you can consider topical steroids, but long-term or recurrent cases, we do use colchicine or Dapsone. But do speak to your dermatology team, and they will help out with the cutaneous manifestations. Now, Kawasaki disease, this is a medium-sized vasculitis, vessel involvement. Usually, dermatology is less of an issue. The main issue is the coronary aneurysm. So if we pick it up early, we'll treat it early. There are some genetic associations, but not for clinical practice. It's morely in Korean, Taiwanese, and Japanese or sort of Chinese population. Now, this is, I've compressed it in one of the slides. This is from one of the papers. And you can see all the clinical criteria or diagnostic criteria in one photograph here. So bilateral non-purulent conjunctivitis, you can see mucosal involvement, palmar or plantar erythema. You can see strawberry tongue, obviously, which we talked about as well. But now if you come down to the trunk, which is E, you can see polymorphous exantheme, primarily truncal. It's not vesicular. So just consider if it's vesicles, do think outside the box. Cervical lymph nodes. So again, full examination of the child. The diagnostic criteria is more than 1.5 centimeter, it should be. And then periangle desquamation and bew lines in the nails. So these are the diagnostic criteria. You can see fever for more than 5, but it's usually after 4 days, the diagnosis can also be made. And on the graph, you can see when these issues happen. So myocarditis is very early in the acute phase. So hence we have to pick it early to help out with the aneurysms. Treatment is less of a dermatological issue, as I mentioned earlier. It is more IVIG and then aspirin later on if need to be. So again, we have to involve pediatric cardiologist and other MDT colleagues. Now coming to Pityriasis and Lichenoides disorders, Pityriasis, there are the common ones are Pityriasis alba, Rosea, Versicolor, Lichenoides, Rubra Pilaris, rotunda, which is rare, and Amiantaceae. Where does the name Pityriasis comes from? So it comes from flaking or scaling of the skin, and it's a Greek sort of word for bran. Pityriasis alba, very common. I see it roughly every week, a few times. It's not vitiligo. So this is pale patches rather than leucodermic or total white, marble white patches. They are not marble white, they are pale patches. Have mild erythema initially. If you can see the left top photographs, can have some scaling, and the treatment is moisturizer. If there is scaling, active scaling, you can use mild antifungals. And later on, for the color changes, you can use calcineurin inhibitor like tacrolimus for 6 to 8 weeks. Pityriasis rosea. So this is a viral rash, usually lasts for 12 weeks. There is a very typical history that one patch started on the trunk somewhere. So if you ask the family, oh yes, I've seen it at least a few times here in the last 2 months of my practice in Pakistan. कि हाँ जी कमर पे या पेट पर एक दाग था और उसके बाद हफ्ता गुजरा और या 4 दिन गुजरे और सारे जिस्म पे दाग बन गए. तो वो basically that's the herald patch, and it's people can easily get confused between psoriasis and fungal infection and Pityriasis rosea. But if the history is taken appropriately and sort of examination, then you will know that this is you can easily differentiate between them. But if it in doubt, do take a fungal scraping. Psoriasis is slightly different, so you will clearly be able to differentiate with the history and physical examination. What are the treatments for Pityriasis rosea? It's a viral rash. So moisturizers, soap substitutes, mild steroids, but sun protection. Unfortunately, repeated sun damage can trigger it up. Pityriasis versicolor. So this is sometimes people say it's tinea versicolor or fungal infection, dermatophyte infection. It's not a dermatophyte infection. But why does the color change happens? Again, interesting enough, versicolor means versatility in the color or difference of the color. It can be hyperpigmented, pale, or even red. So it depends on the skin type, primary skin type of the patient, the Fitzpatrick skin type. And why the color change happens is because of azelaic acid that the yeast produces. So it's not dermatophyte, it's a yeast sort of infiltration or infection, which doesn't let the melanocyte function properly. Now, the other thing is, again, on the history, you can ask if the patient or the child goes out in the sun, does the skin tan? So the infected skin or the involved skin would not tan. If you have a Woods light, you can fluoresce and the color is slightly different. You can see it's a blue-green fluorescence. It can be very remarkable. It can be very obvious. It can be very frightening for the family. And you can see some people will get it confused with vitiligo. I've seen at least 2 or 3 patients in London actually being treated for vitiligo, but it was Pityriasis versicolor. Now, treatment, very commonly we use clotrimazole or ketoconazole shampoo. It's available here, but it used it on, or cream, and it's used on the body. I usually give them shampoo. They can use it as a soap 2-3 times a week, leave it there on the skin for 10-15 minutes and then wash it off because it's a warm environment here. You can use selenium sulfide shampoo, Selsun. There are so many other brands available, but not the common ones. The problem is we need to have appropriate percentage. So it should be 2.5% at least. Terbinafine gel or cycloperex cream, it's widely available, so you can use, but unfortunately I've seen it in combination with the steroids. Don't use the steroid combination here. It takes roughly 12 weeks for Pityriasis versicolor skin changes to completely improve. Pityriasis lichenoides, this is a chronic skin condition. We don't know the trigger, and it's symptomless predominantly. Scaling, very small adherent scaling. You can remove it, and the brown erythematous patches are on the skin. You see them in the emergency department. They certainly come up on the trunk. You get confused with guttate psoriasis, but they are less. They are smaller, and they are only on the trunk. And there are 2 types, Pityriasis lichenoides chronica, which has no symptoms, or there is another one, which is Pityriasis lichenoides advariformis acuta or pleva, which has itchy symptoms a bit, sometimes can be painful as well. And again, sun damage. So sun smart, be sun sensitive, use appropriate sun protection. Steroids, immune modulators. So there is a role of immune modulators, light therapy, but only UVB light therapy, methotrexate or systemic agents, methotrexate, acitretin, dapsone, and cyclosporin for chronic recurrence. PRP or Pityriasis rubra pilaris. I've seen at least a few dozen cases being mixed up with eczema. If it's very much orangey red with some sparing some parts of the body, do consider this. It's rather uncommon, but can present to you. You can see with this, always ask. So when I examine a child for eczema, I always ask the whole skin to be exposed, but the hands and feet. And so you can see here, if hands and feet are involved, do think outside the box. If it's extensive surface involvement in PRP, you can get confused easily with psoriasis. but the history, the clinical appearance gives you the diagnosis. You can do a skin biopsy to confirm it as well. Treatment options, again, vitamin D analogs, emollients, systemic agents, etanercept, which is biologic agent, TNF inhibitor, and UVB light therapy. Pretty uncommon. Pityriasis rotunda, type 1, type 2. Type 2 is more common in young children, so up to 4 years of age, it's been case reported. And but actually, this is a skin is a window for systemic issues. So if you see these hyperpigmented, well-defined circular patches treated for fungal infection, not responding, and you are more concerned about Pityriasis rotunda, and then do think about internal organ disease, malignancy, liver issues, TB. In Pakistan, more concerned about TB and renal failure. So these are the sort of other things to look out for. Less common in children, but leukemia is another thing to rule out for. A differential diagnosis in teenagers, dermatitis artifacta. That's another thing. And in Asian culture, I think hijama, again, that looks like this as well. So do ask about the history if there is something relevant to that. Topical retin, because this is a condition with the which has internal organ involvement. Please do think about treating that or finding that out first. This cutaneous markers or cutaneous presentations improve as this internal disease is catered for, but you can see topical retinoid, salicylic, and lactic acid preparations will help reduce the cosmetic appearance. Pityriasis amiantiasis, this is a term, excessive scaling of the scalp. Regardless of the underlying problem, it can be psoriasis, seborrheic dermatitis, eczema, tinea capitis, so many other things, which can result in this clinical appearance. And it's a French word, amianti. So again, I've explained to you, head lice can also be part of this. I have actually seen 2 patients in the last 2 months here. Both of them have extensive head lice, and that resulted in thick scales. Unfortunately, my other colleagues were treating out in the community, and from other cities, they were treating the children for fungal infection because of the scaling. But once looked in detail, it was actually the main issue was head lice. Once treated, it completely improved. What are the treatment options? Obviously, underlying etiology, you look after the psoriasis, head lice, or any seborrheic dermatitis, other things. But salicylic acid coal tar shampoo will help thicken out or loosen out these thick scales. Coconut compound, it's available if you have compounding pharmacy. You can do that as well, and treating the underlying causes. Lichen. So lichenoid skin conditions. Lichen is found. All of us have seen them. हम जब भी आप कहीं बाहर घूमने फिरने जाएं, वॉक करें, दरख्तों के दरमियान आपको जरूर नजर आएगा. This is these grow on the tree trunk in garden or forest. It's a symbiotic fungus or algae, and that's where the name comes from, lichen. So the skin impression is similar to that. So it can be lichen planus, lichen sclerosis, lichen simplex, lichen striatus, or other things as well, which are less common. So I've discussed 4 of them, and a few of them I haven't discussed today. Lichen planus, people easily confuse it with eczema when it's more in sort of a dorsal aspect. It can be on the wrist area, polygonal raised papular eruption with white striae on the top. Mucosal involvement, always ask for mucosal and genital involvement. It's a T-cell mediated autoimmune disorder. Nails are also involved in this. So you just think outside the box, look at the whole skin rather than just the patch they are showing you. Now, the difference is here we have to use potent steroids, not less potent. And we have calcineurin inhibitors, topical retinoids, interlesional steroids, and systemic agents. Lichen sclerosis. So now you can see, sorry, you can see common chronic skin condition, very common, reasonably, I wouldn't say very, but reasonably common. So these are white patches, mostly in groin, more common in ladies, autoimmune disease. Think outside the box. look at thyroid and other autoimmune, screen for them. It can be predominantly it's genital, but it can be extragenital as well. So these are the extragenital lichen sclerosis. The one on the knee, front of the knee, can be easily confused. Well, people can confuse it with partially treated psoriasis. So please do look outside the box, have a low threshold for investigation or skin biopsy if you're not sure. Now, the problem with lichen sclerosis is it can give you symptoms in young children, where what we are talking about, they might present with constipation. So general pediatrics, when I was doing the general pediatrics training, constipation, always look at the groin area. Don't just give them treatment. Look at the groin area. It can be that there is lichen sclerosis or any other skin problems or any other medical issue which is causing the constipation. General management, and you can see increased risk of SCC. That's the main issue in long term for young ladies, because it's a chronic issue. It can come again and again. Hence, we use potent steroid to suppress the whole immune or inflammatory response to help out with the long term signs and symptoms and improvement. Photographs monitoring, because it's a slow process, we usually advise them to keep on their own digital device. And now, with regards to washing, gentle washing, non-soap cleanser, reducing irritation. Sort of avoid tight clothing. Don't rub the skin. Tap it dry. Other activities like any local trauma, local sort of rubbing, like it can be with a bicycle seat, horse riding, they can aggravate the symptom in the groin area. Now, because it involves the groin area, perineal area, sometimes if there is any issue with the incontinence, seek medical advice. Moisturizers are usually used, and barrier cream, you can use pseudo cream and other products as a barrier to protect the sensitive skin. Management, strong steroids. We don't suggest lower strength steroid. Strong steroid improve the symptoms and then cut it down accordingly. Calcineurin inhibitor, topical retinoids in some cases, and systemic immune suppression. Usually methotrexate is preferred here. Lichen simplex, it's also called as neurodermatitis. It's a localized area of chronic lichenified eczematous or dermatitis patch of the skin. You can see the photograph, excoriated, scaly, localized, thickened sort of patch. And there is sometimes pigmentation issue. If it is hairy part of the body, there can be hair loss as well. Treatment, you can use coal tar preparations, moisturizers, cooling creams, so menthol products. So we have menthol based moisturizers in Pakistan. You can use those as well, or you can compound them yourselves. Or antihistamine, sometimes for extreme itching, tricyclic antidepressants. But some of us might not have experience in those. So please, if you're out of your depth, please refer it to the appropriate physician, and steroids if needed. Now, lichen striatus, there is another reason I've shared this here today. Lichen striatus was referred to me at least 2 times in the last 2 months here as vitiligo. It's not vitiligo if there is pigmented skin, localized blush-coid distribution, then in Fitzpatrick type 4, not 4, but yes, 5, 6 skin, it can present as hypopigmentation. While if you see on the Fitzpatrick type 1, 2, it can present as hyperpigmentation. So again, it depends on the basic skin type where the pigmentation is different, and it's in lichenoid or blush-coid or linear distribution, which gives the clue child is systemically well, there is preceding illness noticed or reported, like upper respiratory infection or any systemic upset, and then this rash comes up. And you can see the blush-coid distribution. These are the dermatomes on the body, and this is self-limiting, uncommon, and possibly genetic triggers, but you can see it resolves. We usually use, my personal preference is calcineurin inhibitors rather than steroids, and mild moisturizers. And with that, I will say thank you very much for your attendance today and joining for this presentation. And huge thanks to DermNet NZ for their educational material. photos and content, and my other colleagues whose slides I have shared today and their photographs. Now, what I would explain, or well, what I will mention here today, this is part of the 6 lectured webinar series for pediatric ER presentation, pediatric dermatology presentation in ER, and every Thursday. The last one is, I think, following on Eid al-Adha. So what we will try to do in the last week, which is the week 5, we will do 2 presentations, one on Thursday and possibly one on Saturday. And the next lecture topic is lumps and bumps, DRESS syndrome, or drug reactions, erythema multiforme, scabies or infestations, cysts, including pilomatricoma and other ones, and head lice. It's on 30th June. Please do. I will encourage you to cascade it into your network so that other people can attend as well. We will upload this video on the Facebook. I've got a Facebook page for where I do a bit of education as well, weekly cases, website, which is obviously dramjadkhan.com, or it will be on Shifa's International Hospitals Facebook and YouTube channel. Now, the last slide, or the last photograph I have shared here, because we have to live a life outside medicine. Pediatricians, I've worked with fantastic people. Pediatricians are very much into fine focus or fine details of things, while dermatologists are, what I've generally seen, are more interested in technology. They're more tech or techie people. So this is the world's first navigation system. We say TomTom, but it's not a TomTom. It's a navigation system. And it was in one of the cars in 1930, Interauto, and this was paper based. So, you know, geographically where you will start out, they will put a paper clip on. The map is already paper built in, and they will tell you where you are on the map. So I was surprised to see this. This is my hobby outside medicine, to read out about weird and wonderful things across the globe. So I will try to bring out something interesting every time, so that we can have something outside medicine as well. So thank you very much, and I'm hopeful that I will see you on 30th of June. And yeah, so you have, I've got a few questions. Let me answer that. I want all right. So the question is it safe to use steroids or other ointments during pregnancy? Yes, they are. Use appropriately. It's the systemic steroids that we are more worried about, rather than topical ointments and creams. And is it safe to use steroids? Yes, it's the same question. Actually, they've put it twice. So yes, I think I've answered that. Other questions, do we? Okay, so one of the colleagues attending today have asked the cure of angular cheilitis around lips. So angular cheilitis is inflammation. Sometimes there is secondary infection. Look out for that. From pediatric perspective, we do worry about anemia, iron deficiency. So basic labs will be helpful. And then again, you can use steroids mildly mixed with antiseptic or antibiotic. So if fusidine-H is available, you can use that. But then let's say if there is no infection, labs are fine, you've already treated the initial flare out and it's recurrent, then sometimes you can use calcineurin inhibitor for the long term. But again, it depends what kind of presentation or the history the patient has. So I hope I've answered all the questions, and thank you very much for joining today. There is no other questions on the screen. So what we'll say it a day for today, and thank you very much, and see you next week.